EXTRIP approach is extracorporeal treatment in poisoning. There are definite guidelines and dialysis is one of them. The choice of dialysis should not be because the level is high. The real question you should answer is dialysis going to change the outcome? The EXTRIP group, the extracorporeal treatment in poisoning, provides evidence-based indications where hemodialysis is useful. So the basic principle is that dialysis works best when the toxin is low molecular weight, has low protein binding, has small volume of distribution, is water soluble, and is causing severe acidosis or organ failure. The classical examples are lithium, methanol, ethylene glycol, salicylate. Let's delve into this. In lithium, why dialysis works is because it is a small molecule, it has no protein binding, and it's renally clear. So dialysate whenever there is severe neurological features like coma, seizures, or confusion. Or by the level criteria in an acute when it is more than 4 milliequivalents per liter, or in a chronic with symptoms when it is more than 2.5. Or there is associated renal failure which impairs the clearance. So chronic toxicity can be severe at lower levels, and levels lag behind the brain toxicity. That is why the levels are lower. Methanol, when there is vision threatened, dialysate, because methanol can be removed, so also its metabolite formic acid can be removed by dialysis. Dialysate in severe metabolic acidosis, whenever visual symptoms are present, methanol level of more than 50 mg or associated renal failure or clinical deterioration. Start formoterol and ethanol immediately, and dialysis does not replace this antidote. In ethylene glycol is converted to glycolic acid or oxalic acid, which produces severe acidosis, severe metabolic disturbance, calcium oxalate crystal precipitation in the kidney, and AK. So dialyze in severe metabolic acidosis, renal failure, or persistent electrolyte rearrangement. The clue in India is unexplained high anion gap plus osmolar gap with acute kidney injury. Think of toxic alcohol ingestion. Salicylate, before intubation fails, you should do it. Why dialysate? It removes salicylates and correct acidosis simultaneously. Dialyze if there is severe metabolic acidosis, altered mental status, pulmonary edema, renal failure, or at levels more than 100 mg/%. The critical pearl I want to say here is that if you intubate without maintaining alkalemia, salicylate redistribute into the nervous system and deterioration occur. So dialysis may be safer than intubation alone.